Hello, everyone. I'd like to invite you to today's webinar, which is hosted by the Association of Physicians of Great Britain and Ireland. And today we'll be talking about fibromyalgia syndrome, new paradigm in the etiopathogenesis. So, fibromyalgia syndrome has been misconstrued and misunderstood for a number of decades now, particularly within the general medical community. So I think this webinar will be an excellent way for us to maybe unravel some of these misunderstandings. And we have three really stellar speakers who are all key opinion leaders in the field of fibromyalgia research and pain research. So I'm going to introduce the first of these, who is Professor David Anderson, who's a professor of neuroscience based at the Wolfson Sensory Pain and Regeneration Centre at King's College, London. His work has really encompassed chronic pain, migraine, and neuroinflammation, with particular work on within experimental models of pain. So without further delay, I will pass this over to David Anderson.
Thank you very much, Usman. Very generous introductions. Thank you very much. I hope I can present something that will be new to most of those that will take part in this. And so I am based at King's College London, and I have a lab there that I run mostly together with Stuart Bevan here at the back. We have for my whole life, I've been studying sensory neurobiology, and not least the transduction mechanisms that sensory neurons use. So the ion channels that sensory neurons use to make us aware of touch, temperature, the presence and absence of chemicals, and so on in our environment. But about a decade ago, I started to work together with Andreas Goebel, who's one of the speakers later here today. And since then, almost all our work has instead become reverse translational investigations of clinically important pain conditions. And this has really provided me with a completely new line of investigations, but also a new driving force to pursue these disorders. So the opportunity to actually perform experimental studies that have direct implications for the clinically affected patient cohorts is really tremendous for me and has really changed how we view our work. All that we do is, of course, focus on chronic pain, and there are many ways of highlighting how important the medical challenge chronic pain is. And I quite like the CDC's number on the prevalence of high impact chronic pain. And here, high impact is defined as having most days compromised from a professional and a family perspective in the last 6 months. And it turns out that 1 in 12 Americans have had the majority of days in the last half a year affected by chronic pain. We can divide chronic pain into either primary and secondary. So primary, unexplained, where pain is the primary pathology, or secondary, where we have pain at least perceived as a consequence of another pathology. We don't have very effective therapies, and in the UK at least, the advice is really to avoid analgesic drugs because they have relatively weak support in meta-analysis. We also divide types of chronic pain into what we view as mechanistic classes, and these are nociceptive, neuropathic, and nociplastic. With neuropathic, not surprisingly, pain as a consequence of damage to the nervous system of the somatosensory pathway, nociceptive as to tissue damage in the periphery. And today we'll focus on fibromyalgia. Fibromyalgia has really was really the condition that led to the inception of the new class, nociplastic pain. And here the intention of the authors, I think, was to refer to pain that's caused by pathways that are intrinsic to the nervous system. So not relying on factors outside of the nervous system. Fibromyalgia is very common. It affects more than 2% of the population, and it's of course characterized by chronic, unrelenting musculoskeletal pain. But what's important for us who study pain experimentally is also that it's associated with tenderness or sensitivity to touch or pressure. Patients typically also live with fatigue and unrefreshing sleep, and often muscle stiffness or weakness. We have long known that the central nervous system is affected by fibromyalgia, but a slew of pioneering studies about a decade ago, not least from Claudia Sommer, but also Jordi Serra and Anne-Louise Oatlander, demonstrated clearly that the peripheral nervous system is also involved or affected in fibromyalgia. I also think it's important to highlight that fibromyalgia is associated with a really severe impact on quality of life. And in comparative studies, fibromyalgia is always towards the bottom end of health-related quality of life compared to other disorders. We have taken note of earlier studies, not least from Andreas and collaborators in Hungary, but we later were also involved in on complex regional pain syndrome, where we managed to show that we can actually transfer the chronic maintained pain that follows CRPS in mice if we take patient antibodies and administer them to mice. We also think it's intriguing that, like many other autoimmune disorders, fibromyalgia is much more common in women than men. So clinically, we tend to see the number 4 to 1, but in clinical trials, it's often even higher. So it predominantly affects women. And while the general population prevalence is about 2.5%, patients that have a rheumatic autoimmune condition in fact have 10 to 30% about 10 to 30% of patients are affected by fibromyalgia. So these were a few of the background reasons that made us approach the question of whether autoantibodies are also involved in the pathology of fibromyalgia. We performed these studies using now quite a classic passive transfer approach, where we purify antibodies, a serum IgG, from healthy donors and from patient volunteers. We then administer them into mice, and we compare the impact of antibodies from patients and control subjects in the mice. And we've used all the different methodologies that we have access to in our labs to explore this. So we've, for example, looked at whether it alters sensory function in the mouse and whether it affects the sensory afferent function, so the sensory nerve function in preparations from the mice. We've tracked where the antibodies go after we administer them to mice. And we've also looked for objective signs of small fiber pathology in the mice by looking at intraepidermal nerve fiber density in skin. And I should mention that we have used in the past similar approaches to study complex regional pain syndrome, and we are currently exploring long COVID or painful long COVID using these approaches. And I like to stress that we don't view our investigations as studies of a mouse model, but instead we use the mouse to study the effect of patient antibodies, of the effect of human pathological molecules. And in these experiments, of course, one of the first things that we did was to explore whether administering antibodies to mice affected their sensory function. And in these experiments, we always compare the effects of antibodies from healthy individuals to those from patients. And here, if we look at, for example, the pore pressure test, we can see that when we give mice antibodies from pain-free, healthy volunteers, we don't see any consequences of the antibodies. We have a relatively unaltered sensitivity to mechanical pressure, as well as to cold. And that's in very sharp contrast to what happens when we administer antibodies from fibromyalgia patients, where we see actually already within a day a dramatically increased sensitivity to mechanical pressure and a reduced cold pain threshold in the mice. This was the experiment with the first patient control pair that we had an opportunity to study, but we repeated that quite a few times. And on average, we see a profile that really looks like that first patient. So when we calculate an average of the first 8 experiments, we see a rapid onset of mechanical and cold hypersensitivity in the mice. To determine whether there's any impact of the antibodies on the sensory nervous system, we tend to use a preparation, electrophysiological preparation, where we have pore skin dissected from mice treated with the antibodies with a saphenous nerve attached. And we can then use electrophysiology to record the activity of individual sensory afferents. We can identify them based on the electrical properties as either A beta, A delta, or C fibres. And then we can stimulate the receptive field with, I think, physiologically relevant modalities like touch, pressure, temperature. to determine whether the function has been altered by the antibodies. When we performed these experiments, we could show that nociceptors, so pain-sensing sensory afferents of A delta and C type, both displayed reduced mechanical threshold for activation. So the mice were more sensitive to cold and mechanical stimulation, and it's tempting to conclude that it was mediated by sensitization of peripheral afferents throughout their bodies. About half of all fibromyalgia patients display a significant loss of intraepidermal innervation. I think that will come up later today because it's the one objective measure that's available to us to study patients with fibromyalgia. So we were, of course, interested to see whether that's also transferred with administration of antibodies to mice. And that was indeed the case. So within 2 weeks of the first injection of antibodies to mice, we saw a significant reduction in the density of epidermal innervation in treated mice. And we have since repeated this a few times. And in collaboration with Usman, who's today's host, Usman Alam in Liverpool, we have actually compared the effect of preparations from patients with and without small fiber pathology. So we compare mice treated with antibodies from healthy volunteers with fibromyalgia patients, with antibodies from fibromyalgia patients that have small fiber pathology or that don't have it. And we see a significant reduction in the epidermal innervation in mice treated with samples from patients that have small fiber pathology, but not from those without. And we think that's very exciting because that seems to suggest that the antibodies are responsible for the fibromyalgia patient status from an intraepidermal nerve fiber density. For me, as a biologist, it's been very exciting to have the opportunity to meet patients and to discuss symptoms in more detail. And in one of these sessions organized by Andreas Goebel in Liverpool, we had an opportunity to discuss the impact of cold with patients. And it was very intriguing to learn how patients describe that it can both affect the pain levels, the pain sensitivity, and the fatigue levels. And since cold or cold environments don't really change our body temperature, that really suggests that it must be mediated, at least in part, by nerve fibers innervating the skin. And we were also intrigued to learn that the touch sensitivity, the quality of touch, might change in cold temperatures, that light touch becomes uncomfortable, or that it changes the textural experience. And this led us to, in collaboration with Usman Alam and Anne Marshall in Liverpool, include a question in a quantitative sensory testing protocol that was simply, what does cold pain threshold feels like? So what does it feel like when you report that you reached the cold pain threshold? And it turns out that fibromyalgia patients were much less likely to describe cold pain as cold, but much more likely to refer to pins and needles or tingling. And this really excited me because these are qualities that you would normally associate with A beta fiber dysfunction rather than C fiber or nociceptor dysfunction. And when we explored what happens in mice to A beta fibers, so these are the fibers that would report light touch or the sensation of clothes against your skin. And in the mouse, they are normally not sensitive to temperature, and that's also what we found. So in mice treated with control antibodies, we didn't come across any out of 30 A beta fibers responding to cooling. Whereas about a third of the A beta slowly adapting fibers in mice treated with patient antibodies had gained cold sensitivity. And that's obviously, to us, akin to cold-evoked paresthesia in a dish, so to demonstrate that cold can evoke sensation of diffuse touch or tingling in preparations from the mouse skin. In people, the situation is slightly different. So a proportion of human SA fibers, A beta fibers, do respond to cooling. But when we had an opportunity to have this re-investigated in humans, we found that the proportion of cold sensitive A beta fibers was really dramatically increased in patients. So that obviously strongly suggests that this gained cold sensitivity is responsible for at least some of the discomforts caused by cooling in patients. So these and many other studies, I think, show that we have peripherally acting autoantibodies because they don't have access to the central nervous system that are responsible for many symptoms of fibromyalgia in patients. And since passive transfer is the most stringent of the criteria postulates proposed by Vitebsky, we think that this, to a large extent, actually justifies referring to fibromyalgia as an autoantibody mediated or an autoimmune condition. We have shown that we can transfer sensory, motor, and anatomical symptoms and signs. So we think so far everything that we have looked for in the mouse seems to be mediated by antibodies. We've also found that multiple different sensory fiber classes are affected. And we think that the fact that we have an autoantibody mediated, at least course of symptoms, really should perhaps lead to reconsideration of whether fibromyalgia is a nociplastic condition, because obviously antibodies act on the nervous system, they're not part of it. Our results also suggest that therapeutic reduction of antibodies, or at least autoantibodies, may be an effective therapeutic avenue in the future. But it may, of course, also be possible to restore the consequences of antibodies, but that might be more challenging. We think we have many things left to do, and to me, some of the most important or exciting for me things to study is to explore whether comorbid fibromyalgia or fibromyalgia is also in fact caused by autoreactive antibodies. And we know that patients typically have structural and functional changes in the central nervous system. And I'm very keen to find out whether that's also the case in the mice treated with patient antibodies. Thank you. That would be all for me.
Thank you, David, for that excellent talk. And it's really nice to see all the hard work that you've undertaken. And I won't refer to your work as experimental models from now on in.
Oh, thank you. Thank you. No, that's a small point that we think has some conceptual value, but I don't expect
No,
people
I
to take that.
completely understand that. So I think I've just mentioned in the chat that we'll be taking questions at the end of the third presentation. So if you have any questions, please do put them in the chat and which individual it's for, and we'll get back to it at the end of the third presentation. So next, I'd like to introduce Professor Andreas Goebel, who is a collaborator, but also is a chair of pain medicine at the University of Liverpool. He's also an honorary consultant in pain medicine. His work has been primarily on understanding the role of the adaptive immune system in causing unexplained chronic pain. He's worked very extensively in complex regional pain syndrome, but also most recently in fibromyalgia as well. He's sat on a number of different groups, including specialist interest groups of the International Association for the Study of Pain. And I'd just like to hand this over to Andreas for his presentation.
Thank you very much, Usman, and thank you for inviting me, and great to be here. And thank you for the introduction. I will see whether this works. Let's just see. Yeah, if I do it like this. So if we look every week in the New England Journal of Medicine, you see these pictures, images in clinical medicine, they're called, and you diagnose, and you're invited to diagnose what these patients have. And usually it's something you can see. It could be a blood test, it could be a scan, it could be something actually with the eye that you can see quite often. But when it comes to symptom-based disorders, it's more like that. The patient reports an awful lot of symptoms, but we can't see very much. Our scans are usually normal, and our blood tests are usually normal. And so what we are showing here is maybe a new way of making the invisible visible. And what David has demonstrated there is hopefully a first step towards this. In the WHO ICD-11, the chronic primary pains are those unexplained chronic pains, and they are all, one can see that here, they're all listed amongst the other types of chronic pain. So these are the pains that are typically having these nociceptive mechanisms proposed. And here are these conditions, and they include today discussed fibromyalgia and include complex regional pain syndrome. And these two conditions were the focus of my research and our collaborative research, but they also include these common chronic back pains, primary low back pains, previously called mechanical low back pains, chronic migraines, irritable bowel syndrome. So this together, they are by far the lead cause of disability, life years lived with disability around the globe. And we don't have solutions for them. So this is we're looking at fibromyalgia today, 2 to 3%. David has already said it. It's not just pain, but also fatigue, poor concentration, poor sleep. And we have neither for fibromyalgia nor for any of these other chronic primary pains, and indeed for most of the symptom-based disorders, we have virtually no good treatments. One should say that light exercise is effective and many patients report that once they got the gist of how to do this, they do report improvements, but it is really a partial improvement normally. David has already outlined these categorizations of autoimmunity, antibody-mediated autoimmunity by Roos and Bone. And I think what we've been doing together fits squarely into these categories. And there's many autoimmune diseases, and maybe fibromyalgia can be counted amongst them in the future. I'm going to show a few results from what might happen downstream of the antibody production, or the antibody being present, and also what happens upstream. This was already shown in our collaboration between David, I, and Camilla Svensson. This was done in Camilla's lab by Emerson Kroc, showing that if you have a patient with fibromyalgia and take their IgG, purify it, and put it onto human dorsal root ganglia, then you get staining, whereas you don't get that with controls. The white is the staining, and the dorsal and the staining is very likely located to small cells around these large cells. So these are the neurons in the dorsal root ganglia, and then around these neurons are these small cells, these satellite glial cells. And it looks like that there's antibodies against satellite glial cells, specifically in fibromyalgia. And if you have more of these antibodies, you have a more severe fibromyalgia condition. That group has done more work on this and have published. We have worked together with Xinsong Dong, who is a mast cell specialist and who had the idea to do this. I had done this before. I'd looked at the role of mast cells in complex regional pain syndrome, and we didn't find anything. We've looked quite well in 2 or 3 studies, and we didn't find anything. And again, that was here reproduced. Xinsong tried it in CRPS and didn't find anything. But in fibromyalgia, if you look in these animals that David has described, that have been injected with patients' IgG, and look in the skin, then you can see here a lot of red dots, and those are all mast cells. So once these animals are injected with fibromyalgia IgG, within a few days, they will show an increase in the number of mast cells in their skin if you compare that with controls. And you can then also co-localize the peritoneal mast cells with an additional stain for IgG, and you can see that they're sometimes covered with IgG. So we think that in addition to binding to satellite glial cells, the IgG bind to mast cells, and Xinsong Dong then used knockout mice to show that if you don't have mast cells, the phenotypes, the sensitivity, and also the several other abnormalities will stop. So these mast cells are, it looks like, really important and may mediate the effect of the IgG. We then worked together with Usman Alam and looked whether we can reproduce something that 2 other groups had already shown in the past, which is namely an increase of mast cells also in human fibromyalgia skin. The 2 groups have shown that 10 and 20 years ago, I think, but they didn't take it further because they didn't, presumably because they didn't quite know what to make out of it. And we found in Usman's sample samples that there was a massively increased number of mast cells in the skin, reproducing what we found in Simpson-Ston's mice. So we can't prove that this is caused by the antibodies, but it's at least paralleling what we find in the mice. And then unexpectedly, when we looked at the tissues, they looked all brown. The fibromyalgia tissues looked brown, resembling the color of our antibody that we used to find and to stain the mast cells, antitryptase antibodies. And it appeared that not only were there more mast cells, but there was also tryptase spilling out into the tissues. And you can see that here a little bit around the cells, there was more staining, and that was rated by several raters. So we think that mast cells are also in human skin activated. And in the mouse, we have by now shown that this is also happening in the muscle. The degree of activation does correlate with patient symptoms. This was a small study in only 20 patients, 20 controls. So the p-values are not very high, but the direction is always into the same direction. This is not corrected for multiple tests, but we think that finding this in such a small group is very promising. So therefore, there's a hypothetical model that B cells are abnormally working and produce these antibodies, which both bind to satellite glial cells and also to mast cells. Whether there's a shared epitopes on both sides, we don't know yet. If B cells do that, then something got to be wrong with the B cells, and we've worked together then with Professor Rachel Bashford-Rogers in Oxford and Alex Lang, and have taken B cell PBMC preparations from our patients and looked how the B cells function, and we could see that with the yellow triangles, when we stimulate them with a T cell independent stimulator, all subclasses of, or almost, all subclasses of B cells pretty much proliferate clearly more, significantly more. And they also have they have different, on B cell receptor sequencing, there are different features that point towards autoimmunity. It's a special type of autoimmunity, though, and Rachel thinks it most resembles what one can see in pre-RA. And before rheumatoid arthritis, people have a build-up of events, of a process that will go into rheumatoid arthritis, which does not happen here. But the differences seem to resemble what one can see in pre-RA. Translating this then towards therapeutic progress, I've plasma exchange 3 of my patients, which worked surprisingly well. Pain impact in the BPI was clearly reduced, and also quality of life was clearly very much increased. Interestingly, pain was improved, but not as much as quality of life. So something is going on there, which is entirely different to what we normally see with drugs that are used for fibromyalgia, where usually the pain is reduced, but then if you look at function, quality of life, not much changes. Here, function and quality of life changed dramatically. Pain and fatigue, not quite as much. So they're having learned that here, we were surprised with that. One can say plasma exchange, this was only one cycle over 3 to 4 weeks. So maybe one needs to do it longer. It's hard to do that with plasma exchange. So it's a limited technology. So I thought, well, maybe if one does it longer, it would be better. We were approached by a company called UCB, who saw the papers and the studies that in David's lab, were done in David's lab in collaboration with us and with Camilla, and they wanted to try their new medication, FcRn inhibitor rozimab, that can reduce antibody in human blood, IgG antibodies, with relatively few side effects. And that study has been completed already and is now submitted, is under review. And the outcome is that 63 patients were enrolled. The reduction of IgG is less than we had hoped for, about 60%. With that, the study was positive, but it was not enough positive. So it was statistically positive, But overall, on the group level, the effect was not big enough for the company to pursue that further. However, there are responders, and we are now looking at who might be a responder. And one is obviously tempted to speculate that if you reduce the IgG level by 80%, which would resemble what we have seen in the animal model, what you need to do, then we might have a better effect. As a final hint here, I would like to share that having done this for a while, I had this lady in her late 40s who had 3 sons with autism, and it occurred to me then that that shouldn't really be the case. I'm not an autism expert, but why would that happen? And I remember then suddenly that many of my fibromyalgia patients tell me that they have children with autism. I normally hadn't paid attention, so we did try and look at that a bit more systematically, and we found that amongst about 500 patients, FMS mothers with who had children had a 15% prevalence of a child, at least one child with autism. Didn't happen in fathers, and it was much higher than other chronic pain conditions, and that at least lets me to speculate that it is possible that the IgG that is pathogenic for causing pain might also have some effect on the neurodevelopment of the child. We cannot prove that at all, but one can test that, and we are hoping to do that. We followed this up with 620 mothers in an online questionnaire, and again, we found this quite strong effect in fibromyalgia versus other chronic pains, which was not dependent on genetic factors. So this seems to be, and we didn't see that in fathers. So there is something must be in the perinatal environment, certainly, that is different in fibromyalgia. So I'd like to remind us that defective B cell tolerance in fibromyalgia is not standing in free air. It usually starts, as we have seen, with experience of severe distress in about 50% of patients, I would say. So something is triggering this, and how this exactly works, I think we should look at that, because it doesn't happen in everyone, so one needs to have a genetic predisposition. It can also happen after infections and after, for example, fluoroquinolone toxicity. All of this is new, and I think lots of reasons to study more. And now there's very new evidence suggesting that that might happen through a change in the gut microbiome. So in conclusion, fibromyalgia and perhaps other symptom-based disorders may be caused by inflammatory non or minimally destructive cell function modifying IgG autoantibodies. The pathogenicity mechanisms, both upstream and downstream, are rapidly being identified. There's lots happening currently. It's really a revolution, I feel. So that novel serum tests and treatments should become available. And these findings may also have implication for progressing our understanding about autism in children, potentially. Certainly, we should look at that. And it should help us to understand how the experience of stress causes the development of chronic pain. Thank you very much.
Thank you, Andreas. Thanks for that excellent talk. And I think you've given a prime example of what one of my old previous supervisors used to say. You conduct clinical research from your clinic. So it's seeing something in the clinic which you can take forward as well and research. So next we have Professor Claudia Sommer, who is a professor of neurology at the University of Würzburg in Germany. She doesn't need much introductions in circles of pain medicine. She's a past president of the International Association for the Study of Pain, or IASP. And her work has primarily focused on the pathophysiology of neuropathic pain. So again, without further delay, Professor Claudia Sommer.
Thank you very much. So this has been really exciting until now, and I'm so happy that fibromyalgia research is being done and that it comes out of this corner of a not explainable disorder. Here are some disclosures, and I'm going to take a slightly different view. You saw this from my title, because so many people say fibromyalgia is not one disease or not one disorder. There are subgroups, and we have to treat these subgroups differently. So my group for a long time has been looking at these subgroups. And one thing which was already mentioned that we found was that a subgroup of the fibromyalgia patients has this reduced intraepidermal nerve fiber density, as you can see on the left in the lower leg, and on the right in the upper leg, compared to controls and to disease controls. This was our first publication with the small cohort, and the next images are from our second publication on that subject with the larger cohort, where we could better subdivide the patients. And here you can see on the right is the skin innervation of the controls, and as it should be, most of them have a normal skin innervation, but they have some that have distally reduced skin innervation that is not unfrequent, but very few have it proximally or distally and proximally at the leg. And in the fibromyalgia group, we also have 37% who have normal skin innervation. Some have it distally reduced, many have it proximally reduced, and there's this subgroup of 15% who had it proximally and distally reduced at the leg. And this subgroup was more severely affected with all the scores and scales that we used. So we were now curious to see what else they had. But before I show that, I just want to remind you that this is not a simple small fiber neuropathy, which is a different disorder, because apart from having fewer fibers, the fibers are also different. You see on the left an electron microscope of fibromyalgia skin nerve fibers, and on the right of controls, and the controls have a normal size of the C fibers in the skin, and in the fibromyalgia group they are thinner, which could also be quantified from the leg, from the hand, from wherever you take that biopsy. So it's a generalized phenomenon. But then we thought, and this was work of my doctoral student Hans Aster, shouldn't we look at the brains, because it is known that certain brain areas are altered in chronic pain and in fibromyalgia in particular, and see whether there are differences between these patients with the small fiber pathology and those who don't have that. And we kind of had this hypothesis that some patients have a peripheral nerve fibromyalgia and others have a central nervous system fibromyalgia. And we found this decrease in cortical thickness in several brain areas, as others had found before. But to our surprise, those people that had the small fiber pathology, they were more affected in the brain than those who had the normal skin innervation. So contrary to our hypothesis, if you had the small fiber pathology, you also had more CNS pathology. And this was not only true for voxel-based morphometry, it was, which I'm showing again here in cortical, measured as cortical thickness, it was also true for white matter integrity, which was also more disturbed in those patients who had the small fiber pathology. So no subgrouping here, except that some people were worse off than others. Another doctoral student of mine, Alexandra Braun, she took a different approach. At that time, we were working on resilience because we had realized that some of our patients were still very successful in what they were doing in their jobs and in their private life, whereas others had retreated into themselves, had a social decline, and we wanted to see how these subgroups, now divided by their degree of resilience, how they would differ. And Alexandra did this cluster analysis and could find 4 clusters, which we then named maladaptive, adaptive, vulnerable, and resilient, and the factor loads were the affective load, coping, pain, and a little bit the pro-inflammatory cytokines that we found systemically. But to our surprise, neither the peripheral nerve parameters nor the CNS parameters did show up in differentiating these clusters. Then, of course, after my colleague's seminal publication on the autoantibodies in fibromyalgia, we also looked in the sera of our patients, and we used a rat and mouse DRG to show the IgG binding of control and fibromyalgia serum. And you can see on these images on the left, a healthy control, then fibromyalgia patients with no binding, then one with small neuron binding, and on the right with large neuron binding. So not everybody had this, but 68 had it, and 116 patients with fibromyalgia did not have this IgG binding, which we consider as reflecting autoantibodies. We didn't see much of a difference between the seronegative and seropositive patients, and especially not in the small fiber counts. Yeah, what we did see were different patterns of serum binding of these patients. So as I already tried to show, some bound to small neurons, to large neurons, some bound to satellite glial cells, and the binding co-localized with different other markers that we used, like TRPV1, CGRP, etc. And we tried to cluster this. And as you can see on the left side, we did find some clusters. For example, there is a subgroup that does not bind to IB4, or in the second cluster that does not bind to TRPV1 expressing neurons. And on the right, you can see how we tried to correlate that with their pain, with the NRS count. And it seems that the more they bound to satellite glial cells, the more pain they had, for example. So, in my conclusion, the small fiber pathology is present in about 50 or 60% of the patients. The more severe small fiber pathology correlates with more severe FMS symptoms in general, also with more severe CNS abnormalities. Antibodies in our cohort are present in about 35% of the FMS patients, but it doesn't correlate with the skin innervation. And some antibody patterns relate to pain characteristics, but actually, although we already have about 200 sera, we would need a lot more to do the statistics to make this clearer. So I think we're still working on building an integrated picture from the FMS puzzle pieces. Andreas showed one which I really like, and that could be a good basis for our discussion. This is my model, but I won't go into it now because time has passed and Andreas has shown similar things. So I'll just stop with that, thanking everybody.
Thank you very much, Claudia, and that was for your excellent presentation. I think we are now, we'll have a panel discussion and maybe questions. At the moment, I don't think there are any questions per se from any of the attendees. So maybe I could just ask a question. Maybe we can have a discussion around this first. So my question to all of you actually is, and I'll pick on one of you to start with, is do you think the small fibres are the first to be effective, or do you think this is more of a central pathology with downstream postsynaptic effects on the peripheral nerve? So maybe I'd like for each of you to perhaps discuss that on what your thoughts are, and if any of you have any sort of any rebuttal on one of the others. comments, then please do interject. So Claudia, I'll maybe ask yourself first.
Thanks. Yes, of course, we don't know. One thing I can say is that this reduction of skin innervation does not correlate with duration of disease in our hands. And the normal loss of fiber density with age is also lost in our cohort of fibromyalgia. So I think it's a primary thing that is there very early, and where it comes from, I don't know. If it were secondary to the other factors, I think it should increase with disease duration, which doesn't seem to do. Although these are not yet longitudinal data, we're working on those. This is from our cross-sectional data.
Sure, thank you. So any thoughts, Andres or David? Maybe Andres?
Can I hand over to David with that? Because
Okay, that's fine. Yeah.
time course in the
Okay.
animal model, it's a time course issue.
Okay.
Yeah. No,
I'm not
David.
supposed to say model. I forgot that again. I always say model as well. So in the animals, it's a time course issue.
yeah. So it may be a time course in the mice. I think clinically, as you suggested, Claudia, it would be very important to perform some longitudinal studies. I've always been intrigued by the possibility that patients may fluctuate in and out of these different groups. And to me, it would be valuable to demonstrate whether or not it's the same sub-cohort that actually remains in the different classes over time. And the other, obviously, most symptoms of fibromyalgia are perhaps not located in the skin. And we study the skin afferents because we have quantitative sensory testing and intraepidermal nerve fiber counts from clinical subjects. But I would dearly like to know what it looks like in other tissues, like muscle, bone, or the sites that we think are perhaps responsible for much of the pain in patients. But that's perhaps not so accessible.
But I mean, is it also, do you think also in the, if you transfer these antibodies now, you can see an effect within 2 to 3 days, don't you? Can't we? So we can see that relatively quick. Obviously, maybe there's already some change in the nerves then as well, which we just cannot see in terms of structural changes. It's possible.
Yeah.
We don't know. The structural
I see what you mean. I see
Yeah.
what you mean with time course. We see the symptoms before we see the nerve fiber loss, definitely.
So that in the animals, the nerve fiber loss probably happens from day 10 or so. So yeah, it's
Yeah.
Yeah.
Give or take.
Okay, thank you. So I think Andres, you touched upon exercise. So I mean, my question is that, coming from a field of endocrinology, where there's actually been some studies in diabetic neuropathy which have demonstrated, or coming from a diabetic neuropathy background, and that's how I've actually got into more fibromyalgia research. But there's some reasonable data actually in regards to exercise and improvement of neuropathic symptoms, and actually even improvement in small fibres. But so I've got two questions. What level of exercise is required? And some of the patients, I'm sure when you see them, they're quite debilitated in the middle when they have flares. So is there any evidence, or is there any data to suggest that actually exercising in flares may be beneficial? Because I suspect that may be quite difficult to do.
Yeah. Thank you. Yeah. And I can maybe also add that our results so far are in people with severe fibromyalgia that can be classified as a FIQR score of 64 higher. I haven't said that before. So there you have another subgrouping maybe. And Claudia's might potentially be slightly different. So it's because our patients actually are quite severe in our population. Yeah. So and usually those who participate in the study. So one should say that in terms of exercising, then it is really that people learn how to exercise despite having the pain, because intuitively you wouldn't want to. Yeah, you would want to rest. you want to kind of have the sense, oh, maybe I need to protect myself. Once they understand that the exercise doesn't cause them harm, then there are gentle techniques to achieve exercising. And overall, in our pain management programs, quality of life improves in large part because people, we think, in large part because people learn how to do certain things, at least through this gentle exercising. We haven't looked at how that affects, for example, nerve fiber pathology. Yeah, it's well possible. What we do see is that it doesn't get rid of the condition, even to a degree that people are happy. Yeah, so it's just something that we can do, which really does something in many people, but it's definitely not enough.
Sure. Thank you, Andreas, for those comments. Claudia, do you have any specific comments on exercise and fibromyalgia syndrome, perhaps in relation to?
No specific ones. Of course, exercise is part of our multimodal program that we offer the patients, and I think nowadays nobody would leave exercise out, but I agree with Andreas that it's probably not enough, and we have to find more specific ways of treating.
Sure, thank you. So actually, staying on that whole area of exercise and perhaps maybe lifestyle. So people with fibromyalgia syndrome, I think the epidemiology demonstrates that they can sometimes, again, we talk about subpopulations, perhaps a larger subpopulation lies in the higher BMI, overweight, or even living with obesity category. And we know that actually from work, again, going back to my own field of diabetic neuropathy and diabetes, that weight loss can be of benefit. So I wonder if maybe perhaps would anyone like to comment on that? I think
Yeah,
there's
it's of
hope for weight
benefit.
loss.
It's of benefit, but it's the same, almost the same as with exercises. It's people, it's a good thing to do, and people will say that, but it's rarely doing very much for the pain itself, unfortunately. So your questions come from a endocrinological standpoint and look really very logical from that perspective. And I always thought, let's try it. And I try to really look out for those who manage to lose weight despite not being able to move much. And there are some who manage to do it. But generally, there is some improvement, but almost similar as with exercise, it's really not enough.
Sure, thanks. Yeah, it's I'm showing the diabetologist in me there with these questions. Claudia, do you have any comments on perhaps weight, and is there anything else that you'd like to add?
Yeah, with the weight, it's a bit like with the small fibers, because so many of our patients are overweight, right? We see this in particular when we need to find the control groups, because we always have to check for control groups with the same BMI, which is often not so easy. And you think, where does it come from? Is it the pain that prevents them from moving, which I think is a bit too simplistic, or is it something underlying? I don't know. I would also be interested what my colleagues think here.
I don't know whether it's just the pain that doesn't, it's interesting, but there is something underlying. I don't know, it could be. But of course, it's clear if you can't really move much, then that by itself is a good reason for weight gain. So, yeah.
Yeah, I mean, it's just interesting. I don't know if David, maybe that could be an experiment that could happen at KCL.
Sure. I'm often sidetracked by
Maybe.
similarities between, say, type 2 diabetes and pain states. So we have obviously some suspicion that cytokines, at least at some point, perhaps are involved. And I was really surprised a few years ago when I learned that in diabetology and endocrine medicine, we think of the pro-inflammatory cytokines in pain medicine are in fact adipokines that are associated with weight gain in diabetology. I also think sometimes it might be worth looking at overlapping disorders that have many overlapping symptoms, but perhaps they aren't identical. So for fibromyalgia, it's obviously in some way quite similar to chronic fatigue syndrome or long COVID. And in those, I think mitochondrial function as a downstream effect of altered substrate use is actually affected, or perhaps even in long COVID because of compromised access to oxygen. So the mitochondrial function in those patient groups seems to be altered, and we don't really know as much about that in fibromyalgia, perhaps, as we could.
Sure, it's very interesting. I think we're approaching the hour mark. I mean, Andreas,
Can I just say something else?
Yeah, go ahead, please.
I just want to say, I think it's much more interesting to look at poverty, for example. So why are these conditions happening much more in people that are poor? So what happens to these people that they develop this, especially if we have this immune? So I think I'm more intrigued by by that. And what does it mean if you're poor? Does it mean that you get more trauma, for example? Yeah, and that then starts this all off, or is the poverty by itself maybe a trauma, having always to look at the bills and so on. We have so many people here in Liverpool that are coming from a really poor background, and maybe if we would understand this better, then that would also be an interesting perspective for public health going forward.
Yeah, absolutely. I completely agree with you there, Andreas. I mean, the question would be, could there be some kind of identification of the at-risk groups beforehand, and then whether they need some kind of psychological support or something else in the background to sort of maybe prevent even the onset of this quite debilitating condition. I think that would probably an important step, but we have to understand the mechanisms first, and I think where the puzzle lies at the moment, or the jigsaw, there's still quite a few gaps.
Yeah.
Any other comments from the presenters? If not, then I'd like to thank the presenters, Professor Andreas Goebel, Professor David Anderson, Professor Claudia Summer, for taking the time to attend the webinar, for the delightful presentation. They're very educational. I'd like to thank the Association of Physicians for holding the webinar, and also for the attendees. Thank you very much.